Welcome to this series of lectures in which we'll discuss important medical topics. Today's topic is about different characteristics of diagnostic tests that help us in interpretation of results of a test. For better understanding of these characteristics, let's see how sensitivity and specificity of a test is established. Suppose we have a group of people in which we know some people who are diagnosed to have disease and other people are healthy. We have designed a new diagnostic test and want to see how good is this test in detecting disease and identifying people who are healthy. We have applied this test to this group of people and these are the results. We can see our new test is able to correctly identify some people with disease and result is true positive. While other people, although they have disease, the result in these cases is false negative. The sensitivity of a test is ability of a test to correctly identify people who have disease. The formula to calculate sensitivity is true positive divided by all people in this group, that is true positive plus false negative, and multiplying it with 100 will give us results in percentage. Suppose we had 100 people with disease and our new test correctly identify 80 people with disease and result was positive in these cases, and 20 cases had false negative results. So if we calculate the sensitivity, it will be 80%. So our new test has ability to correctly identify 80% of people with disease. We can see the sensitivity of a test deals only with people who have disease. It doesn't deal with people who are healthy, or it doesn't deal with whole group. Before we proceed further, let's see that the overall formula for calculation of all these test characteristics is similar. It's true values divided by all people in that group and multiplying it with 100 gives us results in percentage. All these characteristics are percentage of true results in that group. Now let's discuss about specificity. Specificity of a test is its ability to correctly identify people who are healthy. So a test result should identify healthy people and result will be negative in that case. However, we can see that there are some false positive results. Suppose we had 100 people who we knew were healthy and the test correctly identified 90% 90 people who were healthy and result is negative, while the result is false positive in 10 people who will appear to have disease due to false positive results although they are healthy. The formula to calculate specificity is similar. That's the true results, that's true negative divided by all people in this group, that will be true negative plus false positive, and if we use these values it turns out to be 90%. So our new test can identify 90% of healthy people correctly. Before we proceed further, we'll see that once the sensitivity and specificity of a test is established, it will remain same. The prevalence of disease doesn't affect the sensitivity and specificity value. Suppose we have 1,000 people with disease and we'll see our number of true positive results will increase, as is the number of false negative results, but the overall proportion will remain 80%. Similarly, in people who are healthy, the number of false positive and true negative results will increase, but the specificity remains 90%. So we can see the specificity and sensitivity of a test doesn't change with increase in prevalence. Now we have established the sensitivity and specificity of our new test, and we can see it has ability to correctly identify 80% of people with disease and 90% of people who are healthy. Whenever we'll use this test in future, we'll know that our test has this much ability to correctly identify people who have disease and people who are healthy. Up to now, in our discussion, we knew that people who have disease and people who are healthy. Suppose now we want to apply this test in clinical setting. In that case, we'll not be aware that whether a person has disease or healthy, and we want to use this test. When we'll apply this test in clinical setting, there will be two possibilities. Either the test result will be positive or test result will be negative. If test result is positive, we actually don't know if the result is true positive or false positive. But we have a characteristic of test that tells us how likely a positive result is true positive, and that is called positive predictive value. And it is calculated by similar formula with true results on top divided by all people in this group. That will be true positive plus false positive. If we use these values, our positive predictive value of this test will be 88%. So our new test, if test positive, has 88% chances of being true positive, and it means 88% of chances of a person having disease. So will we treat a person based on this 88% chances of positive predictive value? Yes, we may treat if some conditions like streptococcal pharyngitis, which is suspected, and if positive predictive value of our test is 88%, we may give him antibiotics. However, if we need to perform a major surgery or we want to start a patient on chemotherapy, we want to use tests that have 100% positive predictive value. That will mean there is no false positive case and the person is confirmed to have disease. Now, if the test result of this test turn out to be negative, we have another test characteristics that tells us how likely this negative result is true negative, and that test characteristic is called negative predictive value. The formula is similar, that's true negative results divided by all people with negative results, true negative plus false negative, and this turns out to be 81%. So if the test result is negative, it means 81% of chance of person being healthy and result being true negative. As we have seen that all these test characteristics have same overall general formula, and that's true results divided by all people in that group. We have not discussed about accuracy of a test up to now. Accuracy of a test is combination of sensitivity and specificity, and it is calculated by all true values, that's true positive and true negative results divided by all people in that sample or group. Let's discuss diagnostic test with different levels of sensitivity. Suppose we have a diagnostic test that tests positive in all people with disease. This means sensitivity of test is 100%. We know sensitivity of test deals only with people who have disease. It doesn't give us information about people who are healthy. We also know that some people who are healthy, they have false positive results. So our test doesn't have capacity to differentiate if the result is true positive or false positive. Suppose we have 30% false positive results with this test, then positive predictive value in this test will be 77%. We can see although the sensitivity of test is 100%, the positive predictive value is only 77%. In this case, we need to perform further tests to differentiate if the result is true positive or false positive. If the result of such a test is negative, it means the person doesn't have disease, because all the people with disease will have positive results. So this means the person actually doesn't belong to disease group and he is healthy. We can see that if the result is negative, in this case it will be a true negative result. And if we calculate the negative predictive value, it will be 100%. So all the negative results will be true negative. This doesn't mean that this test correctly identifies all the people, because there are some people who have false positive results and they are healthy. But all the people who have negative results are true negative results, and we don't need to proceed further with further workup for them. So in summary, if the result of a very sensitive test is positive, it means we need to perform further tests to know if the test is true positive or false positive. If the result of such a test is negative, it means person doesn't have disease and we don't need to perform any further tests. We use tests with very high sensitivity as initial tests, and this will include all the people with disease, and then we can perform further tests to confirm if the result is true positive or false positive. Similarly, such tests are also used in screening programs. Suppose we have a screening test for a cancer. We'll perform this test, and this will detect all the people with disease, and some people who are healthy will have false positive results. Then we'll need to perform further tests to find which person actually has disease and which are the false positive results. We also perform such tests where even a single false negative result can have serious consequences, like screening of donated blood for presence of viral disease. Even a single false negative result will risk the transmission of virus to recipient. We can see as the sensitivity of test reduces, there will be some false negative results, and this will result in low negative predictive value. The tests with very low sensitivity can also be used in clinical settings. The sensitivity of a test can be increased by repeat testing in some cases, like fecal occult blood test when performed on one occasion has sensitivity of 10 to 30%. But if we repeat the test on 3 occasions, the sensitivity increases to 92%. Similarly, in case of acute MI, ECG has very low sensitivity in early period after MI. If we combine this test with troponin levels and echocardiography, the overall detection and diagnosis rate increases significantly. So we can combine low sensitivity test with other tests to improve the diagnostic accuracy. A test with low sensitivity may have very high specificity, like U wave and ST segment elevation are not found in healthy people. And these signs are very specific for people who have MI. So, as we know, the sensitivity of ECG in early period is very low. These findings may be absent. And sensitivity is only 37% in such situation, with 63% of patients will have false negative results. However, we know these are very specific findings and they will be absent in healthy people. And if these signs are present, it means the person has MI. We can see if the test is negative, the person still may have MI, but if the test is positive, it means the person is most likely have MI. If we calculate the positive predictive value of this test, it's around 92%, while negative predictive value is only 60%. As we know, specificity of a test is ability of a test to correctly identify people who are healthy. If a test correctly identify all the people who are healthy, then the specificity of test will be 100%. In that case, all the healthy people will have negative test results. However, if the result of such a test is positive, this means person is not healthy and he has disease and actually belongs to disease group. We can see another property of such a test is as there are no false positive results, so all the positive results will be true positive in this case, and positive predictive value will be 100%. This means if result of such a test is positive, it means the diagnosis of condition is confirmed. We use test with very high specificity, especially in situation for confirmation of disease before starting treatment, like chemotherapy for cancer that have significant side effects. We also use such tests before performing major surgery. We also use such tests in situation where treatment will be long term and diagnosis will have significant impact on person's life, like diagnosis of HIV or schizophrenia. Now we have discussed about sensitivity and specificity. Let's see how these tests are used in clinical settings. First, we perform a test with high sensitivity that will exclude most healthy people, and it will include all people with disease and healthy people who will have false positive results. After we have excluded most healthy people, then we perform test with high specificity. This will exclude false positive results and test will be positive only in people who have disease, and this will confirm the diagnosis. We can perform these tests in series, like first we perform test with high sensitivity and then we perform a test with high specificity on people who test positive in first test. However, in emergency setting where a rapid diagnosis is required, we can perform all the tests together to establish diagnosis in short period before starting treatment. In our discussion of sensitivity and specificity, it appears that test results are either positive or negative. However, in clinical setting, most of test results are in form of continuous variables. In such cases, we need to establish a threshold point beyond which a person is considered to have positive results. We'll see the example of fasting blood glucose level in diagnosis of diabetes and see how such threshold point is established and how it affects sensitivity and specificity of test. We can see in this graph that we have fasting serum glucose level on x-axis and number of people on y-axis. We can see people who are healthy tend to have blood glucose level on lower side, while people with disease tend to have fasting serum glucose level towards higher side. We know specificity of test deals with people who are healthy and sensitivity of a test deals with people who have disease. We can see due to overlapping nature of graphs of two population, it's not possible to set a point which differentiate all healthy people from people who have disease. In such situation, we need to decide a threshold point beyond which person is considered to have disease, and that result in optimum sensitivity and specificity of test. In this case, suppose we have decided to have threshold point at 120 milligram per deciliter. We can see at this level around 90% of people with disease are correctly identified and sensitivity is 90%. Similarly, 90% of healthy people are also correctly identified and specificity is also 90%. We can see still there are people in both disease and healthy group that will have false negative and false positive results. We can see the optimum accuracy in this situation is achieved at point A, which is usually close to the point of intersection of two curves. Suppose we want to correctly identify all the people with disease. To achieve that, we need to set threshold point that will correctly identify everybody with disease. Suppose we set the threshold point at 100 milligram per deciliter. We can see that all the people with disease will test positive at this level, and sensitivity of test will be 100% at this threshold point. Or we can see that around 50% of healthy people will test false positive at this point. So specificity of test will be only around 50%. So we can see as we have increased the sensitivity, it has resulted in decrease in specificity. We can see due to high sensitivity, there are no false negative results. So negative predictive value in this case will be 100%, while positive predictive value will be 66%. Let's see if we try to identify all healthy people correctly, how it affects the sensitivity and specificity of test. Suppose we set our threshold point at 150 milligram per deciliter. We can see that all the healthy people will test negative at this point. So specificity of test will be 100%. However, we can see that at this point, around 50% of people with disease will test false negative, and sensitivity will be only 50%. We can see as there are no false positive results due to high specificity, the positive predictive value in this case will be 100%, while negative predictive value will be 66%. So we can see as we have increased the specificity, the positive predictive value also has increased. Now we can see other threshold points, like we can see that above the 150 milligram per deciliter, all the test results are true positive, and below certain points, all the results are true negative. Then we have a range in which we find results that can be found in both people who are healthy and people who have disease. So we can perform tests on repeat occasions to know which side they trend, or we can combine this test with additional similar tests like HbA1c to make the diagnosis. We have seen in this example, in case of continuous variables, how sensitivity and specificity of tests are inversely related. For interpretation of a test result, we need to know concepts of pre-test and post-test probability. Pretest probability is probability of presence of a disease before we have performed a diagnostic test. It is equal to prevalence of disease before history and physical examination. After history and physical examination, pretest probability changes based on findings. After we have estimated pretest probability, we perform a diagnostic test and then calculate post-test probability. Post-test probability is probability of presence of a disease after test results are known. There are two methods of calculation of post-test probability. First method is by predictive values. For that, we need sensitivity and specificity of test and prevalence of disease. Other method of calculation of post-test probability is by likelihood ratios. For that, we need sensitivity and specificity of test only. We have already discussed about how to calculate positive and negative predictive values with help of sensitivity and specificity of a test. However, change in prevalence of disease can significantly affect predictive values. For that reason, we need to understand how change in prevalence of disease affects predictive values. Let's see the effect of change in prevalence on predictive values. Suppose we have a population of 1000 people in which prevalence of disease is 20%. Based on this prevalence, 200 people will have disease while 800 people will be healthy. We have a diagnostic test that has sensitivity of 80% and specificity of 90%. We can calculate the true positive and false negative rates in 200 people with disease based on sensitivity of test. Similarly, we can calculate the true negative and false positive test results rates in healthy people. When we calculate the positive predictive value, we can see that positive predictive value in this case is 66%, while negative predictive value is 94%. Now suppose we have another area in which prevalence of same disease is 5%. In that situation, the people with disease will be 50 and healthy people will be 950. When we calculate the positive predictive value, this will be only 29% in this case, and negative predictive value will be 98%. We can see although the total population and sensitivity and specificity of test is same in both population, but change in prevalence of disease affects the predictive values. We can see that with increase in prevalence, there is increase in positive predictive value, while when the prevalence reduces, the positive predictive value also reduces, while the negative predictive value increases with decrease in prevalence. In this example, we'll see the extent to which a change in prevalence can affect predictive values. Suppose we have a population in which a disease doesn't exist. If we perform a test on 1000 people, all the positive results will be false positive, and positive predictive value in this case will be 0%, while all the negative results will be true negative, and negative predictive value in this case will be 100%. We can see that at low prevalence, like 5% in this case, positive predictive value can be significantly low, as we don't want to increase the prevalence of disease. However, we can decrease number of healthy people in equation. That will result in few false positive results and a better positive predictive value. We can see in this example, few healthy people in group leads to increased prevalence of condition in group that will result in better positive predictive value. This can be achieved by performing screening tests on high-risk population and performing diagnostic tests with careful selection of patients. This will lead to increased prevalence of condition in group that will result in better positive predictive value. Now let's see how the sensitivity and specificity of test affects the predictive values. We have seen how change in prevalence of disease affects the predictive values. Another factor that affects the predictive values is sensitivity and specificity of test. In this example, we can see if the specificity of a test is held constant, increase in sensitivity of test leads to corresponding increase in negative predictive value. And when the sensitivity of test reaches to 100%, the negative predictive value also becomes 100%. We have observed this in example of blood glucose level. There is some increase in positive predictive value, but it's not to the extent like negative predictive value. Similarly, if we keep the sensitivity of test constant, increase in specificity will lead to corresponding increase in positive predictive value. And when the specificity of test reaches to 100%, the positive predictive value also becomes 100%. There is some increase in negative predictive value, but this is not as marked as is in case of positive predictive value. In summary, sensitivity and specificity of test is established by performing tests on people who are known to have disease or are healthy, by comparing test results with a gold standard test. Once sensitivity and specificity is established, it remains same. It can be only changed by changing the way test is performed or by performing test on a subset of patients. We know sensitivity of test deals with people who have disease. So if the result of a very sensitive test is negative, this means person doesn't have disease. Similarly, specificity of test deals with people who are healthy. So if results of a test with very high specificity is positive, it means person is not healthy and he has disease. Post-test probability of disease can be calculated by predictive values with help of sensitivity and specificity of test. However, we have seen prevalence of disease can significantly affect predictive values. Positive predictive value can be improved by performing tests on people with reasonable pretest probability of disease. This will result in increased prevalence of condition in group and better positive predictive values. Today we have discussed about sensitivity, specificity, and how to calculate post-test probability by predictive values. In next lecture, we'll discuss how to calculate post-test probability by likelihood ratios.